Hello friends, good morning. This is Dr. Sharjal. Again, I'm with a new video of teaching. Mainly, this is for medical students who are studying obstetrics and gynecology. So this is an obstetrics video, and the topic is antepartum hemorrhage. Friends, let me tell you first. This video is in two parts. So I'll request you to please see another part also for the complete topic. So let's begin. Before beginning, I'll request you to please subscribe my channel so that I bring forward other videos as well, teaching as well as advice videos. So let's begin with antepartum hemorrhage. So here we'll deal about definition, etiology, recognition of potentially serious conditions like placenta previa, abruption, placenta ACRETA, vasa previa, and imaging modalities in diagnosis of APH, management, and controversies and interventions in diagnosis and management. Okay. So first understand what is the definition of antepartum hemorrhage. So antepartum hemorrhage is bleeding from genital tract after 28 weeks and before labor. Gestational age variable is between 20 to 28 weeks, but there is discrepancy in that. But a viable age is 28 weeks. That's why we take here 28 weeks. And the incidence is 2 to 5% of all pregnancies. And what are the morbidity and mortality rates? Maternal mortality in India as well as in UK. In India, it's 29% of maternal death is from antepartum hemorrhage as compared to 0.1% in United Kingdom. And maternal morbidity can be postpartum hemorrhage, anesthesia and surgical risk, thromboembolism, anemia, and sepsis. And perinatal mortality rates 3 to 4 times are higher than normal, and 25% is in case of abruptio placentae or abruption. And what are the perinatal morbidities? These are prematurity, intrauterine growth restriction, congenital malformation, fetal anemia, neurological deficits, or cerebral palsy. What are the etiological causes? The causes are placenta previa 31%, abruptio placentae 22%, unknown or idiopathic causes 24%, show 10%, marginal hemorrhage 9%, genital tract causes 4%, that is cervicitis, trauma, vulvovaginal varicosities, genital tumors. So these causes are 4%, and vasa previa 0.5%. So let's see what is placenta previa. Placenta previa is placenta when placenta is implanted in lower uterine segment presenting ahead of leading pole of the fetus. Placenta lying within 2 cm of overlying internal os. Incidence is 0.4 to 0.8%, 1 in 155 pregnancy. 5% of placenta previa or low-lying placenta is reported at 18 to 24 weeks scan, and 5% of this is reported at term. Now, the classification of placenta previa. Placenta previa can be classified into grade 1, grade 2, grade 3, and grade 4. So grade 1 is also called as lateral or low-lying placenta, that is placenta encroaching to lower uterine segment. Grade 2, it is called as marginal placenta previa, and that is placenta reaches margin of internal os. Grade 3, that is complete placenta covers part of internal os. And grade 4, that is complete when placenta covers internal os when dilated as well. So grade 3 is placenta covers when internal os is closed, but when internal os is open, then placenta doesn't covers whole of the internal os. So this is grade 3. And grade 4 is when placenta covers whole of the internal os even when it is dilated. Okay, so now grade 2 can be classified into anterior as well as posterior. So now classification of placenta previa, it can be classified according to ultrasound findings according to distance of placental edge to internal os in millimeters, distance of overlap at internal os in millimeters, more than 2 cm from os. When placenta is more than 2 cm from internal os, it is called as low-lying placenta. And when placenta is less than 2 cm from internal os, that is called as placenta previa. Okay, so when placental margin is more than 2 cm from internal os, it is low-lying placenta. But when it is less than 2 cm from internal os, it is placenta previa. Now, placenta ACRETA, INCRETA, PERCRETA. That is, abnormally adherent placenta to uterine wall is called as placenta ACRETA. That is placenta which is abnormally adhered to uterine wall. That is placenta ACRETA. It invades uterine muscle, INCRETA, penetrate the uterus, then PERCRETA. Okay. So when it invades uterine muscle, when placenta invades uterine muscle, then it is called as INCRETA, and when it penetrates the uterus, that is PERCRETA. And this condition, placenta ACRETA, INCRETA, PERCRETA, this is rare, 1 in 2500 deliveries. And what are the risk factors for this? Risk factors are placenta previa in 10% cases of placenta previa, previous uterine surgery like cesarean section, myomectomy, age and parity, that is more than 35 years of age is a risk factor, high parity or multiparous is a risk factor, and previous cesarean section. So what are the percentage that is associated with number of cesarean sections? 0. If number of cesarean sections is 0, then placenta previa chances are 0.26% and placenta ACRETA chances are 5%. When number of cesarean sections are 2, then placenta previa chances, when number of cesarean section is 1, then placenta previa chances 0.65% and placenta ACRETA chances 24%. When number of cesarean sections are 2, then placenta previa chances are 1.8% and placenta ACRETA chances 47%. And when number of cesarean sections are 3, then placenta previa chances are 3% and placenta ACRETA chances 40%. Now let's see what are the risk factors for placenta previa. Risk factors are previous abortion, previous cesarean section, multiple pregnancy, previous abortion, smoking and drug abuse, hypertension decreases the risk, recurrence 4 to 6%, associated placenta ACRETA in 10%. Now, how we will make the diagnosis? So, diagnosis can be made clinical and from ultrasonography. We can use MRI also, but let's first discuss clinically. How clinically we can diagnose placenta previa? So, symptoms like causeless, painless bleeding that is associated with placenta previa. 10% of placenta previa is associated with abruption. Other clinical causes, other clinical conditions that we can diagnose from that: malpresentation, free floating presenting part, parabdominally soft and non-tender uterus, fetal heart rate normal. So these are the clinical conditions, that is, and especially painless, causeless bleeding. This is very much associated with placenta previa. And how ultrasonologically we can diagnose placenta previa? We can diagnose transabdominally, transperitoneal approach, translabial approach, transvaginal approach. But TVS, that is transvaginal, is standard, gold standard method. Transabdominal ultrasound is not preferred in case of posterior placenta, that is posterior placenta previa, and fetal head interfering visualization of internal os. Why? In case of posterior placenta previa, transabdominal is not preferred. The cause is because fetal head is interfering in visualization of internal os. And other approach is transperineal or translabial. Let's come to transvaginal sonography. 26 to 60% are diagnosed on transabdominal. Transvaginal sonography reclassifies 26 to 60% that is diagnosed on transabdominal sonography. Sensitivity of transvaginal sonography is 87.5% and specificity is 98.8%. Transvaginal sonography is safe. There are no hemorrhagic complications, and there is advantage in posterior placenta previa also. I told you earlier what are the disadvantages of transabdominal sonography in case of placenta previa. That was posterior placenta previa. So in case of posterior placenta previa, we prefer transvaginal sonography. So transvaginal sonography is advantageous in posterior placenta previa, and there is reduced scanning time. What are the imaging policy for diagnosis of placenta previa? Perform a transvaginal ultrasound on all women in whom placenta previa is suspected at their transabdominal level 2 scan at 20 weeks, and follow-up scan to exclude placenta previa and ACRETA. In case of previous cesarean section, anterior low-lying placenta. Further imaging, who bleed may need as and when required. In case of asymptomatic and minor placenta previa, that is, follow-up can be left until 36 weeks. In asymptomatic and major placenta previa, TVS is done at 32 weeks to allow planning in T3, that is third trimester, and delivery. So what are the recommendations for diagnosis of placenta previa with ultrasonography? TVS for localization at any gestational age when diagnosis of low-lying placenta was made on TAS. When distance between placental edge and internal os reported as in millimeter from internal os. When placental edge overlaps on TVS at 18 to 24 weeks, then follow-up scan in third trimester. When placental edge is between 20 millimeter from internal os or overlaps after 26 weeks, then TVS at regular intervals. Other things we can do as well, that is color flow Doppler ultrasound, MRI. MRI is very good in case of posterior placenta previa and placenta accreta. So MRI is also done when trans-abdominal ultrasound is not satisfactory. If we will compare MRI with trans-abdominal sonography, then sensitivity of 38% to detect placenta accreta and 33% for trans-abdominal sonography. But MRI is costly, and that's why it is unlikely to replace ultrasound. So let's see who are the women who are at risk of placenta accreta: previous cesarean section and anterior placenta. If we will do color flow Doppler, then what we will see, that is diffuse or focal lacunar flow, vascular lakes with turbulent flow, hypervascularity of serosa bladder interface, markedly dilated vessels over peripheral subplacental zone. In case of 3D power Doppler, we'll see numerous coherent vessels involving whole uterine serosa bladder junction, hypervascularity, inseparable cotyledonal and intravenous circulations, chaotic branching, detour vessels. In case of MRI, in case of placenta accreta, what are the findings? Findings are uterine bulging, heterogeneous signal intensity within placenta, dark intraplacental bands with T2 weight images. Let's see migration of placenta. We can see relative upward shift to differential growth of lower uterine segment. Like we find low-lying placenta around 18 to 20 weeks scan, but if we repeat scan at 36 or around 36 weeks, then most of the cases this low-lying placenta is not there because of enlargement of lower uterine segment. So migration of placenta occurs in second and third trimester. Less likely migration is in case of posterior placenta and previous cesarean section. So migration is less likely in these conditions. What are the incidents now of abruptio placentae? Friends, we'll discuss this topic in our part 2 section, so kindly watch my part 2 section for further coverage of this topic, and please don't forget to subscribe my channel, and thank you.